everybody, and welcome to the third Congress Centerpiece session. I'll just introduce myself. I'm Rosalie Viney from the University of Technology in Sydney, and I'm also a member of the iHEA board and had some involvement in the development of this fantastic session. I'd like to begin by acknowledging the Gadigal people of the Eora Nation from where I'm logging in Australia, and to pay my respects to First Nations people across iHEA membership and to elders past, present and emerging. So we've got a really fantastic panel of presenters on what's, I think, a really very current issue for all of us across the world and across iHEA membership. I'm just going to introduce the speakers and provide a little bit of housekeeping matters and then hand over to our moderator, Jane Hall. In terms of housekeeping, because we're in a webinar mode, we ask that everybody uses the Q&A box rather than the chat box for questions to the panelists. So we keep the chat box just for technical issues and general issues. And we'll be monitoring the Q&A box for questions, so please make sure they're posted there. The other thing I just want to do is remind everybody at the Congress about the networking lounge that's part of the Congress. So you can use that to meet up with colleagues. You can go to the lounge anytime in the next 24 hours, whatever your time zone is, see who's there or arrange to meet up with specific people at specific times. The link will be there in the chat box for that. And there's a specific networking session tomorrow. So we really encourage everybody to fill that lounge and try and get an in-person Congress feeling. So it's my pleasure to introduce the speakers for this Congress Centerpiece session. As I said, we have a fantastic lineup. So Susan Cleary is an associate professor in health economics at the School of Public Health and Family Medicine at the University of Cape Town, with 20 years experience in health economics research and teaching, and particularly in economic evaluation. So the other thing is we've got a very international lineup. Richard Holden is a professor of economics at the University of New South Wales Business School and director of the Economics of Education Knowledge Hub at University of New South Wales and co-director of the New Economic Policy Initiative. So he's got a wide-ranging interest in contract theory, organisational economics, law and economics, and political economy. Christian Gollier is the executive director of the Toulouse School of Economics, which he founded with Jean Thoreau in 2007. And before that, he was at the University of Louvain, University of California, San Diego, and he's got a great background that covers many things, including risk and uncertainty, but also environmental economics. And Richard Smith is inaugural Deputy Pro-Vice Chancellor for the University of Exeter Medical School and Professor of Health Economics there. He was previously at the London School of Hygiene and Tropical Medicine, and again, he's got extensive experience. And finally, our moderator is Professor Jane Hall, Distinguished Professor Jane Hall from my own institution, University of Technology, Sydney. So it's a pleasure to have Jane here. I've worked with her for many years. And she doesn't need introduction really, because she's a past president of iHEA and has been a board member, or had been a board member for many years before that. And again, has extensive experience in health economics and health policy research across all aspects of our field. And I also know that, having worked with Jane for many years, that she'll do a fantastic job of moderating this session. So I'm actually going to hand over to Jane at this point.
Thanks very much, Rosalie. No pressure there at all. I too would like to just start by acknowledging the Indigenous and First Nations people, both in Australia where we are, but also in all the countries around the world who are participating in this iHEA conference, and welcome you all to this session. When we started thinking about this session, we were in a slightly different space than we are now with the rise of the Delta variant. And so some of the questions that I think we thought we knew the answers to may be back with some more uncertainty. But I thought it would be useful to start by asking each of our speakers to reflect on the debate that has happened in their own countries, but is probably happening again, about the trade-off between public health and economics. We know that the 4 countries represented here have had quite different experience with infection rates and with deaths, with France and the UK performing badly in terms of high numbers of infections and deaths, South Africa being somewhere in the middle, and Australia so far having done well in terms of infections and deaths. So let's start the ball rolling. And can I start with you, Christian, to just talk about not what France did about COVID in the first wave, but this debate between public health and economics?
Yes, thank you. Thank you very much for the invitation. You are right. At the beginning of the pandemic, 18 months ago, France, as many other countries in Europe, continental Europe, decided to say economics does not matter, only life matters, and we will do whatever it takes to save lives. So that implied that France implemented one of the strongest lockdown during the first wave. And politicians maintained the same message for the next two waves, but actually their policies were quite different from that whatever it takes approach. In fact, during the second wave and even more in the third wave, the actual policy was very different from the doxa of whatever it takes. The government clearly weighted life, save with economic cost, and the consequence that we had very weak social distancing rules, and the lockdown had to be longer to compensate for the low intensity of the social distancing. Well, to go more deeply in your question about how people and government talk to each other about what to do, I contributed to the debate. I wrote a newspaper's article in Le Monde about the value of statistical life, and I must say that reaction was very bad. In fact, there is an impossible debate on the value of life, in spite of the fact that we have very good health economists in France. Let me just mention Lise Rocher, who is quite of an important person in health policy evaluation, and they do a good job, but they belong to a sphere of technocrats. Where, for example, to go back to another example, the one where in France 3 years ago, the government decided to reduce the speed on roads from 90 km per hour to 80 km per hour. And they did that by using a value of statistical life of 3 million euros. And with that number, indeed, reducing the speed was efficient. Spite of that efficiency, most people disagree, and the rule was very hard to implement. And explaining that to the people that the life saved on the road was has a larger value than the time lost on the road because of the reduced speed was extremely complex, and one of the consequences was that this yellow vest movement that emerged in particular from this decision to reduce speed on the road based on a cost-benefit analysis. So let me also mention, going back to the pandemic, that we had no health economist in the scientific council that advised the government about what to do with the different waves. And that's an illustration of the fact that, it's very difficult for the government and for the public opinion to weigh those economic cost and mortality cost. So I'm sure we will debate more deeply on this in the next few minutes, but I think that in France, as in many other places, we should try to create a consensus about health policies it's very hard to make that consensus without sharing explicit common values, in particular the value of life. How can we talk with each other about the intensity of the lockdown, the timing of the lockdown, if we disagree or if we don't share a common value on things like the value of life? So I think we should try to create a public debate about the value of life before the next health crisis. We should try to go beyond the technocratic sphere to convey this idea that the life has no infinite value, and we need to make a decision based on a trade-off between economics impacts and health impact. It's a tricky debate. In particular, for example, if we introduce the age dimension of the value of statistical life, if we recognize that younger people may have a larger value. But let me stop here at this stage. So to summarize, in France, we didn't have a debate about how to weight economic cost and life saved. Thank you.
Thanks, Christian. And I'll come back because that answer raises some very interesting questions. But let me go to the UK and Richard Smith. Rich, the UK was quite slow, I think, in implementing lockdowns. But tell us about the debate of public health versus economic activity. And you, of course, are a health economist technocrat, probably.
Well, it wasn't in my bio that Rosalie did, but maybe we should add it in, Jane. That's a good way to finish the bio, isn't it? Yeah, I mean, the pandemic, of course, just highlighted brilliantly, in fact, the links between health and the economy, which I guess most of us are well aware of. And the balance really between the impact of the policy options and interventions versus COVID itself, which I think was quite interesting. So as with France at the beginning, lots of discussion and statements that health is the most important thing. We must do all we can to protect health. Massive lockdown initially. By the time they got around to doing it, after the horse racing had finished, we then had the lockdown, which was all about protecting health. But actually, I think it changed fairly quickly. I think that after probably just weeks, lots of discussion there around what the impact was going to be on the economy of all this. So, if you think about the interventions, there were massive public health interventions. Lockdown was the extreme, and there were different severities of lockdown. We've been in and out of those at various points, but we had, and various countries had different ways of doing testing and tracing and tracking, school closures on and off, social distancing, vaccine developments and deliveries. All these things are really huge public health interventions. Most of them hadn't been done before, were being done in some haste, I suppose, because they sort of had to be. Fairly limited evidence. And although we had some concern about, the health service and the surge, most of the debate, I think, was from the economic side around jobs. So then we had another intervention, which was jobs retention scheme, kind of called furlough, but basically the government is paying people to not go to work, essentially. But then on trade, access to goods, access to food, what would this mean for long-term health impacts? And that would mean for future recession and so on and so forth. So I think quite quickly, the economy in the public debate, and I think actually in the private, more policy debate, came to sort of dominate. And I think if we look at what's going to happen on Monday the 19th, the economy is effectively won because we're removing everything. So, and then it doesn't matter, we'll have 100,000 cases a day or more. That's the government predictions. And actually it's fine now, we've had enough. The economy can't cope, that's it. So that's been the ultimate change in message from where we started on day one, which is, as you said, Christian, everything to protect health. Well, clearly not, because now we're just going to let it go. Hope vaccines will sort it out and then move on. I was very interested in that and was part of it, I suppose, at the beginning, because of previous work around SARS, the first SARS in 2003, and then pandemic preparedness plans. So actually quite early on in 2020, just after Christmas 2019, we were repeating our macroeconomic models around pandemic impacts. And I presented some of that in April at a webinar at iHEA, but the short story of that is taken up in the publication process. So we're trying to publish it in around about March, April time, and this thing was at peak. And the journals were saying, we're going to reject that because your results are just too extreme. Now, if you go and look at the paper, which Social Science and Medicine eventually took, they're the most conservative estimates going if you're looking backwards now in history. But at the time, they were seen as, that's ridiculous. It could never have that size of impact. That's ludicrous. So, kind of where you put the debate in that, because the uncertainty levels are so massive, and it's out of your range of experience, that actually some of the things that were being suggested seemed utterly incomprehensible because they were so dramatic. Now we've got hindsight, it's quite a different state. So I think the role then, and the question of the session, of course, is where does economic evaluation fit in that? And I'm sure we'll pick up a lot of those issues as we go through, but it's really interesting where economic evaluation didn't fit in that, actually.
Yeah. And we will come back to that, and we'll come back to the uncertainty issue. But let me move on to Sue. And again, for your experience and your perception of the debate in South Africa.
Thanks very much. And hi, everyone. It's great to join you from a wintry Cape Town. We're really sorry that we weren't able to see you in person here in Cape Town at the moment, but we look forward to seeing you here in 2023. So in South Africa, similar to the other countries, we started with a hard lockdown in late March 2020, and everything other than essential businesses was closed. We weren't even allowed to go outside to exercise. But I think it's important to bear in mind our economic context. So we're a highly unequal middle-income country with approximately 30% unemployment, and the economy contracted by 17% in Q2 2020 during our hard lockdown. And there were serious concerns about food security. And one of the shocking things we saw was drone footage of long lines of people queuing for food support during hard lockdown. And we have ongoing concerns that any economic contraction would contribute to violence and destabilization of the country. And unfortunately, at the moment, we're seeing some of that unfold. So while government did put economic relief measures in place, these are difficult to sustain in our context. For example, many high-income countries have low or even negative real interest rates. But in South Africa, our real interest rates are in excess of 5%. So in 2022, 50% of the debt we raise will be to service the interest on our debt. So given the above, we ultimately eased lockdown to enter our first wave back in June 2020. And we had a substantial wave, and we hoped we were through the worst of it. But then we had an even worse wave during summer over the festive season, which is December, January here. And that was driven by the new beta variant. And while we did introduce some additional NPI restrictions, in my view, we sought to keep the economy as open as possible. So where are we now? Well, we are currently in the middle of our third wave, which is being driven by the Delta variant. And this is despite the fact that research from blood donors suggests a national prevalence of 47% after the second wave. And despite the fact that we actually are worse affected than the UK and France, in that we have a cumulative excess death rate of more than 300 per 100,000. You can't look at the official figures from South Africa. You have to look at excess deaths, which are well reported in our context. And we normally have about 500,000 deaths from natural causes per annum. But since COVID, we've had an extra 180,000, and it's been incredibly difficult for us. So at the moment, we are in a stricter lockdown. But again, on the whole, most businesses are open. We closed restaurants for 2 weeks recently, but we've just reopened them again, and we are yet to peak with our third wave. So that's how it's played out in South Africa. Thanks very much.
So really then, Sue, not much debate about the trade-off between the economy and public health, really just moving to protect the economy because of those range of factors you've identified.
Yeah, after an initial hard lockdown, which did go on for about 6 weeks or so, I think that we together as a nation, unfortunately, we just can't afford it. And so I think as much as possible, we've sought to keep the economy open. But of course, without international tourists, we're still suffering.
So let me move to Richard in Australia. Richard, you're not a health economist in the sense that Sue and Rich and I would identify ourselves, but you did become very vocal and have remained so, I think, on the debate about the economics and public health. So over to you.
Yes, thanks, Jane. That's a very nice way of saying it. Yeah, I'm not a health economist, but I am a loudmouth. So I got involved in the Australian debate about this. You know, as Jane would know and Rosalie would know and some others may know, Australia's been very, very fortunate. So, you know, one of the things, you know, Jane and I are both sitting here in different parts of Sydney from a lockdown of sorts at the moment with the Delta variant. But, you know, Australia's really been very, very fortunate. The economy has done extremely well and bounced back. We went into our first recession in 30 years briefly. but things have really bounced back, and we've done incredibly well on the public health front. And in sort of by any measure, we've had incredibly low case numbers and death rates. So we've done very well. Now, how did that come about? One thing is it's kind of good to be an island, at least if you close your international border, which we did in March of last year from all countries. Now, some people could come back. There were some exceptions, and there was a slightly leaky hotel quarantine system put in place. But basically, we closed the border in a pretty hard way, and people had to spend 14 days in quarantine coming back into the country, regardless of where they'd come from. And that really kept a lot of the cases out. There was basically a brief debate in Australia towards the end of March and early April of last year. And, a number of people said, particularly business figures and some business journalists said, we've got to worry about the economy. There's this big trade-off. In fact, we're about to do too much for health, the sort of thing that a number of people have raised. And most economists, in fact, I helped organise an open letter to the Prime Minister and the National Cabinet, which comprises the premiers of the various states in Australia, as well as the federal government. And that letter, which was signed by, I think, roughly speaking, all bar one academic economist in Australia, basically said there are trade-offs. Our whole life's spent analysing trade-offs, but that means there's a trade-off somewhere in the policy space. In the particular part of the policy space Australia's in right now, there is no trade-off between public health and the economy. We're in a position where we've got 80-odd cases and 3 deaths from this virus. And if we can keep it out and give ourselves time to build up testing, which we had very little of, contact tracing, which we had basically none of, and get a better understanding of what's going on with the virus, if we can get these things in place, then it'll be better for public health, and that will be better for the economy. And so we had a national lockdown of roughly 4 weeks. There was certainly not having people's doors welded shut. People could exercise, people could go to the dry cleaner, people could go get espressos. It was clearly very hard on some sectors of the economy, the hospitality industry, the tourism sector, of course. We normally have 9 million arrivals a year in Australia, in a country of 25 million people of population. And the tertiary education sector, where we have a lot of foreign students, was hit incredibly hard. The government put in place extremely aggressive fiscal support measures, the order of 15% of GDP in terms of fiscal support. As Sue alluded to, we're a country with negative real interest rates, even able to borrow very long term for 1% nominal, so negative real interest rate. And the government really put that support in place, and we did well on both counts. Now, there continues to be a sort of lingering debate about did we do the right thing or did we do the wrong thing? But the public have basically spoken about that and said, looks like Australia, at least with our sort of lucky geography and economic geography, did the right thing. It's worked well. Unemployment's considerably lower than pre-pandemic. GDP growth is higher than pre-pandemic. We obviously had a dip, but things are considerably better now. And what we're really trying to do is get our vaccination rates up so we can reopen properly.
Thanks, Richard. Well, there's a number of issues, I think, to pick up from here, but let's start with the issue of uncertainty, because one of the things about this pandemic was the level of uncertainty of what we were dealing with and the speed with which it arrived and with which it was spreading. So what does that mean for making sensible public policy, for optimal policy, when you face such high levels of uncertainty and such pressure to act? Christian, this is something I know that you've thought about. Can I toss that to you to open up on?
Thank you very much. I'm a decision theorist, so I'm not a health economist. So indeed, I was attracted in early last year to think about how to manage a pandemic where we face such large, deep uncertainties. I mean, remember February, March 2020 in Europe, what was the level of the R0? What we didn't even know what was the pandemic situation. We couldn't know because of the large number of asymptomatic cases. It was very hard to estimate the number of infected people, how many people already recovered from the pandemic. So it was very hard to, even calibrate a simple SIR model in that case. We also had a lot of uncertainty about the impact of policies on transmission. What was the effect of a face mask on transmission? What was the effect of the intensity of the social distancing on the R0? How much time we need to develop a vaccine at that time? Remember, we think of the vaccine will take at least 2 years to be produced. Even we didn't know we didn't know what was the economic cost. We didn't know the efficacy of teleworking. That 2 years ago, I mean, we just didn't know what's the economic consequence of a lockdown. So the consequence is that it was very hard to perform cost-benefit analysis. For example, comparing different policies such as flattening the curve, remember the wording, versus crushing the curve, which is called now zero COVID or no COVID policy. It was extremely difficult to perform cost-benefit analysis. We don't know when we don't know the value of all those parameters. Well, it was hard at that time to think of the trade-off between the intensity of the lockdown and the duration of the lockdown to crush the vaccine, the virus. So in that circumstances, in particular in France, and remember in France, we politicians live under, under the risk of what we call, the tainted blood scandal in the 80s, where at the beginning of the HIV crisis, the French government take bad decision to support some policy that had heavy consequence in terms of people dying from the HIV, and that tainted blood scandal had deep consequence, I believe, on the decision that was made in March 2020 to impose an extreme, very strong lockdown. We applied the precaution principle. Okay, that precaution principle that most health economists know, I believe. So what's very pregnant, I mean, very present in the debate last year. So we act before we learn rather than we learn before we act. We believe that the option value to wait to see what was the R0, but by letting the virus circulate in the population, the option value to wait to learn was too small compared to the cost of letting people being infected by the virus at that time. So and probably even more than this debate on the option value to wait, it was more a political science issue of political credibility and public trust. I mean, public trust in France is very important. The credibility of the government is very weak, and it's partly due to this tainted blood scandal 40 years ago, 30 years ago. And so, from the eyes of the politicians, the need to preserve political credibility and public trust was really critical in the decision to say whatever it takes, we will save life, and value and the economic cost is irrelevant for that decision. Keep in mind also, and that go back to the previous discussion we had earlier. I mean, in France, many people believe that we will never have to repay the debt created by the COVID crisis because Europe is there to pay for it, and also interest rates are so small that we can increase debt without any cost. So keep also in mind that science last year didn't say much about what's the consequence of all those deep uncertainty on the optimal strategy. Okay, what does decision theory say about the impact of uncertainty? Well, not much at this stage. Economists as you know, many economists around the world use these IR models to optimize health policies, but they did that assuming we know all those parameters. Okay, and it was quite problematic last year in particular. It's still problematic, but last year it was deeply problematic. So I think we should, and there is still, this provide a long agenda for research. We should approach SIR models with parametric uncertainty and using stochastic optimization technique as we do in macroeconomics and in finance. I mean, so we should adapt the pandemic modeling from the one used by epidemiologists, and we should recognize that we need to optimize not under certainty, but with uncertainty, and knowing that we will learn better about all those unknown parameters later on and how this future learning process affect the current decision. And that's of course related to the precautionary principle. I work myself and I published a paper last year for what happened when we don't know DR0 at the beginning. We start a very strong lockdown, but we don't know what's by how much DR0 will be increased if we reduce the lockdown, and how this uncertainty about the R0 under a reduced lockdown, how that uncertainty affect the initial intensity, optimal intensity of the lockdown. That's the paper. That's the question I raised in the paper that I published last year. But I must recognize that the outcome of that paper, I still do not understand the outcome. So it's not very useful when you cannot explain the outcome of your model to the lay people. I mean, I believe this is not very useful. So let me finish with, we still face many uncertainty today, okay? The duration of immunity of vaccination, it's a big source of uncertainty. Frequency of new variants and the value of their R0. We see with the variant Delta that, catastrophic things are still possible. Remember also that if we would not have those vaccines earlier this year, the situation will be absolutely dramatic. I mean, we just forget about the scenario that did not happen, but that could have happened last year without the vaccine. And with the arrival of those variants, the British variant and the Indian variant this day, which is much more contagious and more deadly, I mean, we would have 10 times more death that we face today, and we should have entered in much stronger lockdown that we face today. And maybe we are also facing that situation today. We could imagine in some scenarios more variant, more deadly, more contagious, and that's raised the question of what we should do today. Okay, so we also have uncertainty about, and we should not recognize that. I mean, we also face uncertainty about the long-term side effect of vaccine. And this, is a debate related to those this strong movement of anti-vaxxers in France, but also in other countries. And it's true that we face uncertainty about that. How do we solve that? So let me stop here, just saying precautionary principle in that framework is not very useful, because you have two-sided precautionary arguments here. On the one side, we don't know the long-term effect of new vaccine, and the precautionary principle should tell us in that case that we should postpone a massive implementation of this vaccine in the population. At the same time, we don't know the frequency of new variant and the value of their R0, and the precaution principle should tell us to impose a very fast vaccination campaign in that framework. And so you see, this precautionary principle does not say much about what we should do today in the face of those uncertainty. Thank you very much.
Thanks, Christian. I'm going to go to Richard Holden, because I think, Richard, you might like to pick up on some of this, but part of the uncertainty, and I think some of the points that you've picked up in your public comments have been around this interplay of health and economics, and that part of the uncertainty is about, you know, what the economic damage would be, and the difficulty in understanding how these two factors interact with each other.
Thanks, Jane. Yes, I mean, I completely agree with Christian that we were facing, you know, really radical uncertainty last year. And at least the way I saw that was that by doing something to try and stop an exponential process getting out of control, by being sort of firm early, that gave policymakers options. It gave them options to think about what to do later on, whereas countries that didn't take firm measures early on, once an exponential process is really going, it's, you know, much more costly to stop and very difficult, and may not even really be possible to stop. So I think that taking firm measures early on was very important. And I think a lot of what was important about the interplay that actually feeds into the public policy debate was that recognizing that there was going to be severe economic dislocation and putting in place really significant fiscal support. So, you know, a lot of countries obviously put in place very significant wage subsidies, understood that people were going to, you know, who were able to work from home were going to be working at home. But if you shut down schools, that means a whole lot of people are going to have to deal with, you know, having their kids at home, not being at school. And, you know, a whole number of people, you know, who'd be listening to this and who are on the panel know exactly what that was like. And so I think a lot of countries recognize we need to put in place sort of government-funded leave programs for people. We need to put in, you know, for Australia, for instance, suddenly had free daycare that we didn't have before, free childcare that was not in place before. Now, sadly, that's gone away, but for a period of time, that was a conservative government putting that policy in place. So I think these things were deeply interconnected, but that actually, at least in a number of countries, by spending heavily, and, you know, countries that were able to do that didn't have over the top debt to GDP ratios, that had low interest rates and that were able to do that, by spending heavily, it gave really space to be able to deal with the public health issue. And so I saw that, and I see it much, you know, very much through the lens of the Australian perspective and Australian policymakers. We were hugely informed by what was going on overseas. And one of the things, you know, just to tie it back to the point on uncertainty that you raised, Jane, and that you know, Christian's devoted a lot of his career to studying formally, was that Australia at least had the chance to see some of what had gone on in Italy, for instance. And at the time that we really started having a serious public discussion about here, we'd seen, you know, an Olympic ice rink in Spain being used as a morgue, and we'd seen what was going on in Italy. And that was both tragic and really scary and really instructive for countries like Australia, and we were able to act. So being able to reduce that uncertainty in some way, however that can be done, was hugely valuable.
Yeah, thanks, Richard. I'm going to come to Richard Smith now, but I just want to say to people, thank you for the questions coming in on the Q&A panel here. Please keep them coming. I will stop at various points and get responses to them. But Richard, you know, we've taught economic evaluation together in the distant past, and we always start with the whole idea of opportunity cost. And yet in this situation that we found ourselves, opportunity cost just wasn't something tangible anymore. And that was a real challenge, I think, to our economic evaluation techniques. Would you like to say a bit more about that and how we should try to cope with these sorts of challenges?
Sure, thanks, Jane. Yeah, I think some of it gets back to the, in a sense, the interventions I started with. You know, kind of what were the things we were looking at, and if we were to evaluate them, what things were we evaluating? What are the things that policymakers want to know, and they want to know it now because they need to make a decision. So alongside the uncertainty, as Christian said, you've got that kind of speed. You know, we need to do something. What should we do? What are the options? The options are things like, do we lock down the entire economy completely? Do we do it geographically? Do we do it by sector? Do we just close schools? If we do, how long? Should we close our borders? You know, should we take that approach? Do we close them totally? Do we have a little list of countries that we're happy with? How do we prioritize hospital care so that we can cope with surge? Do we build temporary hospitals? Do we just stop every routine procedure? But how long do we do that for? Should we pay people to isolate and not go to work? You know, these are big issues, and it's really interesting then, what is the opportunity cost of locking down your economy? You know, that kind of, the principle is still there, but I think again we're back to this, it's such beyond the magnitude of things that we're used to thinking about, that it creates real kind of stress in terms of how to deal with it. And I suppose there's 2 points to that, but I just want to make briefly. One is, and particularly as economists and as technocrats, as you said we are, Jane, you know, there's a lot of default to quantitative work. And in this sense, we had to default to models because we didn't have the luxury of observing. And it just struck me, because I just wrote in a comment to Tony Scott on the Q&A, that actually our planning was really good. It was really good for what we planned for. The problem was what we planned for didn't happen. Something else happened. And so our models were based on the thing we thought might happen. So the quantitative work actually didn't help us very much in the first instance. So the opportunity cost that we were thinking of there didn't quite equate to what was actually the decision faced. And I think we got a bit locked into that. I say we in the grand scheme of things, as the technocrats, but also the policy rhetoric got stuck in this groove of we're following the science, and that implied we're following quantitative evidence of knowing what will happen, or at least being able to know what the uncertainty is, for example, to get back to Christian's point. Whereas actually we didn't know anything like that. We did a paper on this in PNAS last year, which I know Christian knows, but looking at rational policy making and focusing on the importance of the normative in all this. And actually that was something that wasn't very well dealt with, I think, in terms of the public rhetoric. We got in and out of, we don't know what's going on, we're trying to do the best, with we're following the science, this is what's going to work. And I think in some ways we were probably slightly complicit in that from the academic side as well, in not paying sufficient attention to the normative in all this, and trying to be very quantitative and trying to kind of produce business as usual with a model, by and large, that probably doesn't work for doing that.
That's interesting. And Sue, I want to bring you in on this too. The epidemiologists have got away with this though, haven't they? Without really admitting to uncertainty and producing all sorts of models. You're just smiling. I'll take that as agreement. So sort of over to you and your sense about what these challenges are, that, you know, and what do we do with our supposedly tried and true methods that are very good for marginal decision making, but should we just abandon them in the face of something so massive?
Thanks, Jane. So I think that we have to accept that COVID is an amazingly tricky virus. And in my experience, it's really important to work in interdisciplinary teams and to encourage respectful communication. And I've been lucky to be involved in some teams like that in the COVID response in South Africa. And I also think the timing of, in terms of the early response, I think the timing of the first wave was key. And I think it's understandable in a way that there was limited EE input in the global north, given the sudden onset. But for South Africa, in similar settings, we had our first cases in March, but our first wave only peaked in June, July. So we had quite a bit of time to prepare. We had a good couple of months to prepare ourselves and to learn from the global north. And there were publications that came out from the global north that we could learn from. And so economic evaluation and more broadly health economics thinking was used in South Africa since the outset of the pandemic, particularly to inform health system decision-making on things like ICU, expanding ICU, purchasing ICU, building field hospitals, PPE, medicines, and the like. So I think that it is possible to use the more straightforward models, cost effectiveness, cost utility models, to look at interventions within the health system. But I think it's fair to say that the epi modeling, Jane, you referred to the epi modeling. I think it's fair to say that the epi modeling of future waves of COVID-19 has been fraught. And I think that in our context, we have some amazing people doing epi modeling, and they've done their best in a difficult situation. But this is a new virus. It behaves in surprising ways, and the emergence of variants has certainly complicated things. So I think because of this, it's quite difficult to do forward-looking cost-benefit analysis or an economic evaluation of alternative NPIs. And so what we focused on ultimately was very simple economic evaluation models of inpatient care. And I think that those can work. But once you start trying to integrate an epi model into your economic evaluation model, it becomes very complicated, and it becomes very difficult to use the model to gain insight into what's going on. And there's the potential to give incorrect policy guidance. I think in the future, we will have a great time building all kinds of models to look back and understand what has happened. But during the early response, I continue to think that it was best to keep it simple. Thanks.
And so where do you think we should be going now? I mean, now, you know, for example, we've got a number of different vaccines, different prices. Is that going to be tractable to this approach, or is there still so much uncertainty really that we shouldn't be using it to compare different vaccines or vaccine strategies?
Thanks. I mean, it's obviously always wise to use your resources judiciously. If you can get an outcome at a lower cost, then you obviously need to do so for reasons of efficiency and equity. And it's not only about the price of the dose, it's also how many doses are needed, what is the relative delivery cost, et cetera, et cetera. But, you know, as I mentioned, COVID is extremely tricky, and I thought I would share some anecdotes from South African experience of vaccines to explain what I mean. So back in January 21, we had about 3 options in terms of the vaccines that we felt were safe, effective, and acceptable to our population. These were Pfizer-BioNTech, the Johnson & Johnson/Janssen, and the Oxford AstraZeneca vaccines. And at the time, I was part of the Ministerial Advisory Committee in South Africa, and my view is that we should prioritize Johnson & Johnson or AstraZeneca because they were both approximately 4 times cheaper than Pfizer. And so for reasons of efficiency and equity, particularly with the Johnson & Johnson, a one shot, you know, cheaper was the way to go. And we didn't have Johnson & Johnson yet, so we organized AstraZeneca, and we intended to use it for our healthcare workers. But then results of trials showed that AstraZeneca may not work that well against the beta variant that was dominating our second wave in South Africa at the time. And so we therefore pivoted to Johnson & Johnson for our healthcare workers and went and sold our AstraZeneca to members of the African Union. And this also largely meant that we missed out on the first tranche of COVAX, which we also paid for, because the first tranche of COVAX was largely AstraZeneca. Now, this was a very controversial decision, and I can't go into all of that, but needless to say, now that we have the Delta variant, we're definitely kicking ourselves for not having used AstraZeneca. So how have things gone with Johnson & Johnson? Not so well. We have concluded bilateral negotiations, and it seems we've procured approximately 31 million doses. Our first consignment of 2 million arrived in May, but then the US FDA found that the doses that were manufactured in a Baltimore plant in America were contaminated, and we had to destroy our doses. And so given the above, Pfizer has ended up being the vaccine that we have predominantly used so far. We have vaccinated about 7% of our population once with 1 dose, using predominantly Pfizer and a small amount of J&J. So what is the moral of the story? Yes, price and cost effectiveness under pre-COVID levels of uncertainty should be a key consideration, but this is a very tricky virus.
It is indeed, and a very, very tricky situation. So shall we move to sort of how we might go forward then? And should we be having a different sort of conversation about health and economy now? Because we haven't got the same levels of uncertainty we had 18 months ago. We have still a lot of uncertainty and new uncertainties popping up. but we do know more, even if it's perhaps what we don't know. How should we be moving the debate forward? And I'm not sure who it's fair to toss that one to first, but Richard Smith, why don't I come to you? How should we be facing these sorts of challenges going forward?
Thanks, Jane. I suppose I'm thinking about who the we is. So if I'm thinking in terms of we as the
good question.
If I'm thinking as we as the health economists, I'm gonna bang my usual drum for more macroeconomics. You know, so we focus a lot on microeconomics in terms of economic evaluation, cost effectiveness, potentially into cost benefit. And I think that we can discuss a bit more, of course, ins and outs of it, but that's probably at the core here. I think we've had fairly little impact in what's happened in the UK as a health economics profession, because we don't really have the tools for it, because our tools are predominantly economic evaluation or some variant of microeconomics. And actually those big questions hit the economy, they hit GDP. We've heard more about GDP this year than ever before, and different sectors and so forth. And that really, and the sorts of models that they're looking at there are the macro models, and we have very limited, expertise in that. So I think that, as the we for us as economists, I think that is really key. I would say that because I do that sort of thing. In terms of we as a country, I think it's raised the link between health and the economy. So I think if we look at some positives that come out of it, I think the discussions about the importance of employment and education and the impacts of that on mental health, physical health effects of exercise, with more people on bikes and out running than we've ever had before. So from a public health point of view, some of those aspects have been really good side of it. And I think keeping that focus on the economy and health are really intrinsically linked. It's not a debate on one or the other. It's how they both work together to reinforce each other going forwards. And I think we've had a bit too much of what do you think from a health point of view? What do you think from an economic point of view? And the debate should be how we bring those closer together to work to going forwards, because they will feed off each other and they will both be damaged if one of the other is damaged, and they will both benefit if they're one of them benefits.
Thanks. Good answer. And can I see if anybody else would like to comment on that? Richard and Christian, yes?
Yes, well, to go back to the basis to the previous discussion we had, I mean, I think we have a problem, and politicians have a problem to rationalize their policy decision. And so the consequence is that today people are lost. I mean, in France and probably in many other countries, and in the UK, variant Delta is there, and wherever they are getting out of social distanciation. I mean, people are lost. It's rational to adapt beliefs to new information. And these rational beliefs are fluctuated in dramatic waves of the ups and downs of the last 18 months. So when we, in that very tricky uncertainty, as Susan mentioned, I mean, of course, we get new information, bad and good, the new variant, new vaccine, efficiency, better than expected. And so, of course, in that fluctuating uncertainty, we need to adapt the public policy to those new information. And the problem is people have hard time to do that. People are today, they are lost. I mean, we are in France, we get out of lockdown earlier this spring. We are going to strengthen the social distanciation in the next few weeks. They don't know what to do. I think we need to help politicians to prepare for contingency plan, and those contingency plans should be clear and science-based. Something that we were not able to convince politicians to do. And let me be clearer on one dimension. With a large fraction of the population now vaccinated in France, and with an easy and completely free access to vaccines, I believe that the responsibilities have shifted, are currently shifting from politicians to citizens. Okay, I believe that in the next few months in Europe, most death will be for unvaccinated people, and anti-vaxxers will continue to ignore the positive vaccination externality, but they will be overwhelmed by their own mortality risk under the fourth wave and by the new incentives coming from the COVID passports that are currently implemented in Europe. So I don't believe that restriction to economic activity could be reintroduced in Europe in the next few months. They could be reintroduced only in case of a doubt on the efficacy of our vaccines to new variants. But so to summarize, I think that part of the problem has shifted from politicians to the people, and however, we need a vision. We need politicians to propose a vision about what will be done next few months in a contingency way.
Thanks, Christian. Richard, do you want to come in on this at all?
Yeah, I'll just say briefly, and I think this picks up a lot on what Christian said, that vaccines are a real game changer when it comes to this. And, you know, when there was a discussion about so-called living with the virus, you know, this time last year, what that really meant was dying with the virus, because there were sort of no other ways to keep things under control. Now, you know, it's kind of been incredible, these mRNA vaccines and the technological development. And you know, the fact that there's a debate about a vaccine like AstraZeneca, which in ordinary times we think of as being incredibly high efficacy with relatively minimal, at least short-term, you know, side effects and relatively low risk. But, you know, Pfizer and Moderna have come up with extraordinary vaccines. And that really changes everything. And that's exactly the discussion that countries with relatively low vaccination rates but low COVID are really having. And one of the things that was very frustrating about the public debate in Australia, our vaccine rollout went very, very, very slowly, even though we could have bought enough Pfizer or Moderna for the entire country very early on. We could be like Israel right now, or even more highly vaccinated. Our government chose not to do that, to wait and see, which a lot of people told them at the time was a very silly thing to do. And then when the rollout was very, very slow, said, we've got no COVID, so we can take our time. And in fact, the political phrase that was used by the Prime Minister and the head of the health department was, it's not a race. And, you know, any economist worth their salt was sitting there saying two things. Firstly, of course, it's a race. And secondly, you know, it's a race to open up the economy. It's a race to get people vaccinated. It's a race to provide protection, and so on. And the second thing was, just because you've got no COVID now doesn't mean you're not going to have COVID in a month's time, which we do now. And so I think there's some pretty basic kind of sort of dynamic optimization. You know, you don't need to be able to solve a Bellman equation to figure that out. You just need to understand that, you know, you're making decisions now and the future might be different. You need to take that into account. So I think the vaccines are the real game changer, and that, again, provides policymakers with options.
And of course, that leads us to another interesting point, really, around vaccine nationalism and richer countries grabbing what they can get, and sort of letting poorer countries do what they can. And yet with such an infectious disease, there's a lot more interdependency there than there has been in many other things that we've seen. Anybody want to comment or reflect on that? And then I'm going to go to the questions because I'm conscious we're running out of time. Christian, I think you're...
Yeah, so, you know, I wrote 3 papers on COVID last year in 2020, and in November, I decided to stop because I believe my legitimacy was quite limited. But then we got this third wave in February, March this year, and with the vaccination possibility that opened a new dimension in the modeling of cost-benefit analysis of different health policies. So I went back, I introduced vaccination in my models, and I wrote a new paper that I published later this year. Yeah, it's, you know, with such large difference in the mortality risk across ages, remember, people over 65 are a 1,000 times larger probability to die if they get infected compared to people below the age of 25. So in that framework, it's completely clear that we should prioritize the vaccine dose to the most vulnerable people. And not doing that, in particular at the early time where the vaccination capacity is quite limited around the world, not doing that has a very large welfare cost. And so one of my objectives in that paper was to estimate this welfare cost. So what I did, for example, I calibrate my model for France. And so what I did is, suppose you have two Frances, one with same initial condition, same R0, same everything, except that one country, one France has the capacity of 200,000 doses per day to produce, and the other France has nothing, and wait for importing doses from the other country. And so I compare two outcomes, one where the vaccine production capacity in one country is first devoted to vaccinate everybody in that country before allowing the vaccine dose to be exported to the other fronts. And I compare that second best policy, this vaccination nationalism, equilibrium or solution, with the other one where that's first best, where we share the doses across the two countries at the same time, starting with the vaccination of the most vulnerable people and then going down the ladder of the mortality risk in the population. And the difference is extremely large. I mean, the country with the production capacity can save most of its people, whereas you will have extreme mortality in the other country, not counting even the economic cost for the other country. So one point, so the welfare cost of vaccination nationalism is extremely large around the world. Second, the benefits of production capacity for those countries that can have one is so large that indeed it's very hard to believe that one day we will be able to have an international treaty where we would organize the first best solution. I mean, all the production countries will keep their capacity as much as they can because the people will not allow for export before they get their dose first. And the numbers are quite striking in that dimension.
Thanks, Christian. Let's go to some questions. We're scheduled to end in 15 minutes. And in the last 4 or 5 minutes, I'd like to just give each panelist a chance for a final comment. But looking at the questions, Rosalie, I don't know if you've done more analysis or if I should just go down this, start going down this list. Lisa, thanks for the comment about tools. I think that's probably something more for iHEA to pick up and think about rather than the panel. So I'm going to say, nice to know you're here, and but probably we should take that as a comment. Rosalie, you're going to help me now. You're on mute.
Awkward moment when you can't find the non-mute button. So I thought perhaps an interesting question to pick up would be Tony's question around the pandemic planning, and put it together with, I think there was a question from John around vaccine hesitancy, because both of them, I guess, have focused on the questions around research on behavioural policy. And how that might come in. And so I think Tony's question is really saying, is there more that we could do in terms of thinking about that sort of research and how it might fit into pandemic planning and being informed by societal economic evaluation. And John's question was about vaccine hesitancy as a rational response to some of the things leading up to the panel and whether people had lost trust in institutions. And I think that sort of thinking about the behavioural issues is there. So yeah. I've tried to roll two questions together.
And in fact, I think we could broaden that a little, because it's not just vaccine hesitancy, it's also sort of contact tracing and tracking hesitancy, which we certainly saw quite a bit of early on. Who'd like to respond to that?
I'll just say one thing very quickly on that, which is I think this loss of trust in institutions really plays into that a great deal. So for instance, you know, contact tracing done through, you know, cell phones and, you know, and we've seen various countries be able to have a very, very, very effective response based on that. Now, if people care about their privacy, as I certainly do, you really have to believe that governments aren't going to use this stuff for purposes that they say that they're not going to do it to. And of course, it's, you know, hard to commit to that in a legal sense in advance. You need institutions that people believe in and that work well, and courts are part of that, and various other institutions of civil society. And I think those things are incredibly important. And what part of what goes with that as well, people have discussed for many years, is this kind of loss of trust and faith in experts. And we've seen that, sadly, in my view, you know, with the climate crisis and various discussions around that. And, you know, there's a real, there's been a hugely important role for experts here, epidemiologists, you know, a field that a lot of people would never have even heard of before, you know, some economists included. And, you know, it's become incredibly important. Technical advisory groups giving vaccine advice, saying, if you're over 60, you should or shouldn't have this one. If you're over 40, you should or shouldn't have this one. Huge impacts on people. And I think that really as countries, as nations, and, you know, thinking very seriously about making those institutions strong and respected and long-standing is incredibly important for public confidence. And again, if that can be the case, it gives policymakers more options. And that was no more apparent, you know, very starkly when it comes to things like being able to track people's movements based on their cell phones. If people don't trust you that you're going to not use that information for illicit purposes or untoward purposes, then they won't allow you to do that.
May I add something here? I mean,
Please.
yeah, credibility and trust is critical in this crisis, where externalities are very important. Positive vaccination externality, negative virus contagion externality. That's critically important. And so social interaction are key. Trust is key. You know, it's quite impressive to see. So, for example, these days, 2 days ago, in fact, President Macron announced that vaccination for nurses is now compulsory. Okay, and he was also announcing that the government was considering the possibility of imposing vaccine to everybody. So that's for a country that promotes liberté, fraternité, égalité, you know, that's quite of something. And that's the consequence of, you know, our lack of trust. I mean, making things compulsory, making things for the common good compulsory rather than having, I mean, that should be natural for the common good to do. So that says something about how problematic our democratic societies have become in a world where credibility and trust are fading. So that's, I think, it goes far beyond the pandemic crisis. You mentioned, Richard, the case of climate change, my field specialty, it's exactly the same problem. So I think it's critically important for government to re-establish credibility and trust. So they need to explain more clearly what are the arguments in favor of their policy. They need to defend their policy to the people in order for the people to better understand the meaning and the reason for those policies to be implemented. And most of the time, government don't have the energy and the will to do that. And in the long run, it's becoming very problematic. And health economists are key in that framework in the dimension of the pandemic here.
Right. So, Rosalie, is there another question that jumps out at you?
So there's a question about whether we need methods that look more explicitly at uncertainty in other economic fields, such as climate change, robust decision-making, so shifting the focus away. And then there's a couple of questions around the mental health impacts and the weighing up the mental health impacts, and then I guess what the role of health economics might be in recovery planning. So I'm trying to sum up a few in a go.
So let's get a comment on that and then we'll do some summing up.
Okay, so from the robust control is something for me, I believe. Yes, I agree. I mean, what's our objective? Under uncertainty, what do we want to optimize? And should we recognize risk aversion? Should we recognize regret? You know, do we want to minimize regret rather than maximizing expected utility? Under ambiguity on the true probability distribution, should we be ambiguity averse? That's related to robustness control. Yeah, that's key question. And at this stage, we are just opening the window, looking at those questions in the dimension of, you know, health crisis. I'm not a specialist, but I can help, I think.
And Sue.
Thanks, Jane. So on the non-COVID health impacts, including the mental health impacts, I mean, I think of course, those are equally important in my view. And of course, health economics and economic evaluation specifically can assist in priority setting and thinking about where we should be putting our money. And, you know, that's what we should have always been doing. We should have always been thinking about what benefits we offer within our universal health coverage system and whether they are cost effective, affordable and equitable or not. So I think that, you know, there's no point in controlling for COVID and then getting other larger health impacts in other areas, and all health impacts are equally important in my view. And some are even more important, particularly depending on who they impact. And so we have to think about the vulnerable groups and so on and so forth. But in South Africa, we're very worried about mental health and TB and immunizations and assisted births, and all of those other impacts are also extremely important. Thank you.
So in fact, we've sort of got this cascading potential, haven't we, of an intervention and then another intervention to ameliorate the side effects of the first intervention, and so it goes on, and that can make for some very complex modeling. There's another question here, which I think is worth thinking about, and that is how we evaluate different lockdown policies according to their stringency. And so using something like a stringency index, should we be really doing more about, I guess, we talk about a lockdown as though all of them are the same, and yet they're not, and there's different levels of stringency. Should we be doing more looking at that? So you're nodding.
Well,
Christian?
No, go ahead.
Yeah, so we did have one cost-benefit analysis that was very controversial that was done sort of to argue against lockdown in South Africa, approximately April last year. It was very political, and I think ultimately was very incorrect in terms of its assumptions about the trajectory of the epidemic in terms of the deaths that we actually did eventually get. I think that they were highly optimistic and extremely incorrect about their projections, and argued that lockdown had lost a lot more lives than COVID ever would, which was wrong, I think. And so I think that we don't have an appetite for more of that kind of thinking at the moment in South Africa. And sort of I think we tend to try and plan more in the short term. And I think that given the uncertainty and given how quickly things change, and I look at what I prepared for iHEA a month ago is no longer correct. And my answers of today are only correct today. So I think that this is the situation we find ourselves in. And so too much debate about what's going to happen in a year from now, I don't think is terribly helpful. Thanks.
Thanks. And Christian?
Yes, you know, in climate change, we know what to do. We need to reduce emission, and it's easy. I mean, relatively easy to measure emission and determine what action to have a collective effort in that dimension. For climate, for COVID, it would be nice to have something similar, but of course, the preventive efforts are multidimensional. I mean, wearing mask, social distancing. This is very fuzzy. I mean, very fuzzy concept. I mean, what kind of mask, how much time, where to wear it, all those things are important to determine what's the optimal policy. And as long, I mean, we need to get a macro measure of the effort in order to better shape of policy. And but of course, it's a long-term endeavor. I mean, we still are not completely sure about the impact of specific action or on the contagion and the dynamic of the pandemic. If we could do that, I mean, it would be easier to talk about, you know, whether to allow sport event in open air and dancing places. I mean, we still are not completely sure of the benefits of prohibiting this or that. And so that should be, that's important. That's something important to be done in the future.
Okay, if I don't wrap up now, we're going to be cut off very inelegantly, I fear. Thank you to all our panelists. Thank you to all our participants. We've had over 150 people here. Unfortunately, this format doesn't really allow us to do the questions and the comments justice, and I'm sorry for that, but really pleased to see those comments and questions coming in, and I think there'll be food for thought in the future. Let me just go around the panelists and give them a chance for a final word, but ask them to keep it to no more than a minute so that we don't just get cut off unceremoniously. Richard Smith.
Thanks, Jane. Two things. First, we need more macroeconomics. I have to say that, you know that. The reasons for that, you can look at a paper in 2008 in Health Economics around economic analysis of public health emergencies of international concern. Second point is, picking up on the social science side, I think our rhetoric has been follow the science, not meaning social science. And I think actually what would rectify that is if, as well as a chief medical officer and chief scientific advisor who always stand next to the Prime Minister, we should have a chief social science officer, and the first incumbent should be a health economist.
Thanks, Rich. Sue.
Thanks. I mean, it's certainly been a fascinating 18 months, and so many of the things that we thought would pan out just hasn't worked out like that. And I've been working in a school of public health, so for me, there's been a lot of public health truths that have been broken. So we're dealing with an airborne virus. We thought that there would only be 3 waves like the Spanish flu. We thought that there would be no variants, and if there were variants, that they would be less transmissible or less virulent. And we thought that each wave would be lower than the preceding one. So I think that what I take from it is that it's really important to be humble, to be comfortable to admit that we are wrong, and that admitting mistakes can be comforting because it means we are still alive and we are still learning.
Thank you. And Richard?
Thanks, Jane. Thanks to everyone. I think what I'd say is that if the 2008 financial crisis was really a moment for financial economists and contract theorists and all sorts of macroeconomists to really feel like they had space to try some new things and revisit a whole lot of assumptions about their discipline. This seems like a time where it kind of should be health economists' moment to shine. And if anything good can come out of this, and there's a lot of bad, then I hope that it will be that health economists will be put more at the forefront of helping to integrate all the various different interdisciplinary research that goes on these really important issues.
Thanks, Richard. And Christian.
Yes, thank you. First, let me congratulate my fellow health economists here on the virtual table. I mean, they are the right person at the right place, and good luck with the remaining of the pandemic. Let me just say a word on. I think we need an advice. I mean, I think we should get out of the technocratic sphere, promoting the idea of the value of statistical life. We need to have a debate on how much we want to put value on life compared to economic activities. And without that, in the next pandemic, we will face the same problem for politicians to argue on what's the efficient policy to follow in a situation like that.
Thank you. And I'm sure there's a round of virtual applause going on for all our panelists. I'd also like to say thank you to Rosalie for bringing so much of this session together, to Di, and to all of the iHEA team behind the scenes. It's all worked wonderfully well. Thank you all very much. And maybe we'll all see each other in person at the next iHEA meeting.
And thanks for chairing, Jane.
Thanks, Jane.
Thanks, Jane.